Hi guys, Dr. Dillard here. It is week 5. It's the spring of 2020. It's Thursday, and here we go, CVPP lecture for today. Let's talk about arteriovenous fistulas. So AV fistulas. Fistula is an abnormal communication between two tubes, right? We've talked about that before. In this case, arterial means it's an artery and venous means it's a vein. So it's an abnormal connection between an artery and a vein. This is not the same as the arteriovenous shunts or the arteriovenous anastomoses, which are normal. Those are a part of capillary systems. An AV fistula it's a pathology. You're not supposed to have these things. Remember, the AV anastomosis is right here. Usually, it depends on the state of the tissue here. If the cells, draw a couple cells here, if they are happy and they don't need oxygen, well, then this opens up and we can save blood flow. We can let blood flow right through here, arterial blood, and get into the venous system and save that blood. There's no sense of feeding tissue that is already happy, right? On the other side, in another way that these things can open up, we've talked about this before, if you have hypotension or hypovolemia, the body will release, or the adrenal gland, the adrenal medulla will release epinephrine, which binds to receptors here, and it causes the smooth muscle to relax in this case, and it allows blood to flow right through this tube. Same thing with arginine vasopressin. Remember, we said that if you're dying, we don't need to feed the skin blood, so these arteriovenous anastomoses can pop open and save blood from going into the skin and keep blood in the core system to try to keep your pressure up. All right. So the problem with these AV fistulas, if you have this going on, there's no control over it. It's open all the time, and therefore the downstream tissue is getting cheated with regard to blood flow. Blood is flowing right into the venous system, and depending on how big the fistula is, it can be trouble for the downstream tissue. It can become ischemic and start to hurt, and plus all the extra blood flowing into the vein. The system isn't designed like that. It can stretch the vein out and make it varicose, and it can dump too much blood back into the heart, which can lead to too much blood flowing through the pulmonary microvasculature, which can lead to scarring and vasoconstriction and basically a beaver dam in the lungs, and the right heart will try to overcome that and wear itself out. Have we gotten to, I can't remember, no, we haven't gotten to yet, but we will talk about atrial septal defects and ventricular septal defects in Eisenmenger syndrome. That same kind of phenomenon goes. So here's the normal system, right, where your arterial blood would come through here, and it would go feed the tissue. Here it goes into a capillary. Let's say these cells are hungry, they need oxygen. Some cells need oxygen all the time. If they're not hungry and they don't need to be fed, we can open this AV shunt up here. There's no communication here, but an AV fistula is an abnormal communication between these two things, like this picture. So this patient developed had an infection which got into the two nearby arterioles and venules, and they fused together during the infection process, and because of the high pressure, it bore a hole right here, which is a fistula. And now we have way too much blood returning to the heart, and the blood is stretched the artery way out, or the venule way out, so we have a varicosity on top of that. What causes these AV fistulas? They can be congenital. They can be from birth. AVMs, we'll look at a certain type of AV fistula here in a second. That is, most of the time you're born with this abnormal connection. But they can be acquired as well, like inflammatory necrosis secondary to some inflammatory condition, like cellulitis. You get some type of infection in the skin and it gets down into the blood vessels and causes a vasculitis. Could be an autoimmune attack, Berger's disease. Sometimes you can develop these AV fistulas between the posterior tibial artery and its double satellite vein system. Penetrating injuries, if you get a scalpel injury or a catheter injury or a needle injury or a bullet or a sword, if you're sword fighting, get stabbed, the inflammation to heal those vessels can result in a communication between an artery and a vein, and that's an AV fistula. Where do they usually occur? They can occur anywhere. Unfortunately, they like to occur in the CNS, including the brain and the spinal cord. Arms and legs, they can occur there. Remember the satellite veins? I don't know if they taught you that. I used to show my students those satellite veins that would run side-by-side arteries. But yeah, there's anywhere side-by-side veins and arteries are, they can occur. They can occur in the lungs. When they occur in the brain, it's given a special name. It's called the AVM. So we'll see here in a second. So what's the sequelae, or what's the outcome of AV fistula? May be small, and you may not even know you had it. There may be completely asymptomatic, but if it's big, it can cause downstream ischemia and start to cause death of the tissue. For example, if it occurs between the radial and ulnar artery and vein, or the radial artery and the cephalic vein, or ulnar artery and the cephalic vein, you can cheat your hand out of blood, and your hand can start becoming painful, especially when exercising. Right? It's also could cause hypertrophic cardiomyopathy, because if you have, let's say you have one of these in a big artery and vein combination, let's just use the same cephalic vein and the radial artery, the blood will, or the body will sense that the hand is not getting enough blood, and the heart will pump harder to try to properly perfuse the ischemic hand. And in doing that, the heart could start to wear itself out, especially if these things are all over your body. Therefore, it could also raise blood pressure. And as we said, it can blow the vein out, because the vein's not supposed to handle that high of a pressure. The vein is supposed to handle pressure that comes from the venule. Its pressure slowly builds, but it never gets up that high. The vein is not designed to handle that arterial pressure, and it becomes varicosed, or you get a varicosity out of that, varicose vein out of that. And the varicose vein could pop, and there you got yourself a dangerous hemorrhage, intercerebral hemorrhage, or even a subdural hemorrhage, which is not, we talked about how dangerous that is. So here's an example of an anastomosis between the cephalic vein and we use the ulnar artery here from a patient who had an infection of some kind, and it got into the blood vessels and they fused together. And so now the arterial blood is dumping into here, and it's really high pressure, plus it's too much volume. It's not designed to take that much pressure or volume. And so cephalic vein can get really, really ugly looking. If you did an Allen's test on this patient, and when you tested the ulnar artery, what are you going to find? It's not going to fill, right? It normally takes about 5 seconds for the circulation to come back in the hand. If you did this, it's not going to fill. It's going to be white looking. So they'll have a positive Allen's test. All right, so here's this is an India case where a patient is, for whatever reason, they didn't worry about the arm, but now they're having trouble breathing, and they're having dyspnea and chest pain, and they have pulmonary hypertension and right heart failure. How come? Because of that same AV anastomosis between the, I think that was between the ulnar, I think that was between the radial and the cephalic vein. But cephalic vein takes all that blood, and look at all the extra blood. It's stretched out the cephalic vein to a ridiculous degree. But it's all dumping into the heart. That's too much blood to be dumping into the heart. And it's bombing the lungs with too much blood, and the microcirculation is getting scarred up from that, and it's resisting that high pressure because the microcirculation around the alveoli, it has a certain pressure that it likes to be. So the arterioles will vasoconstrict to try to control the pressure, and that causes a beaver dam. And the right heart wears out really fast by this scenario. AV malformations, those are AVMs. They are a subcategory of arteriovenous fistula. They can be quite dangerous. They're prone to rupture and hemorrhage as well. But the key with them, AVMs, are typically in the central nervous system, which I should have put the very first slide. These are CNS problems. And it's more than just a fistula. It's a congenital kind of anomaly where you have basically a tangled spider web of arteries, extra arteries, and veins and fistulas between them. So it's just a mess. Got a good picture. But that can cause downstream decreased flow and tissue ischemia. And if that happens in the brain, that's not a good thing, right? There's a beautiful example of an AV malformation in the brain, and you can see it's not good. We got varicosities of the downstream blood vessel or downstream veins because they're not designed to take that higher pressure. And usually found in the cerebral, like middle cerebral arteries, anterior, posterior cerebral arteries, cerebellar vasculature. They can occur in the spinal cord as well. They're responsible for about 2% of all strokes that occur. Here's an extramedullary, meaning it's outside the spinal cord. Intradural, it's inside the thecal sac, though. And there's one right there, the 64-year-old. Positive Babinski sign. They thought they had a MS, but it pushes on the posterior part of the spinal cord. It can give you these upper motor neuron lesion findings. Some more epidemiology. The prevalence of AVM is about 0.02% of the population, so twice as common as Marfan syndrome. 2/3 of these are diagnosed by the age of 40. They're not as dangerous as Berry aneurysms. If they hemorrhage, about 4% of people will die with this. 4% of them will hemorrhage, and that carries a 10% chance of morbidity. Remember, a Berry aneurysm hemorrhaging carried a 33% fatality rate. So neurological sequelae, they can still cause serious neurological stroke-like symptoms, right? They'll cause a stroke. What else do we got here? The symptoms, they could be completely asymptomatic until the rupture occurs, until it hemorrhages. And they're often discovered and just kind of caught them incidental findings or incidentally on imaging. About 12% of people with AVM will develop brain symptoms, signs of ischemia like a seizure, paresis, muscle weakness, loss of coordination, severe headaches, memory problems, stroke symptoms, speech difficulties, dizziness. And I think we've talked about that. Here's the AVM here. So we have blood flowing here. And normally blood would go down through this microcirculation system or arterial situation to feed all these cells of the brain. Maybe these are your Broca's speech center. But if you have one of these things, a lot of the blood is going to be shunted off, and it cheats this. It bypasses this. So very little blood flow gets to this region, and it can become ischemic and could even die, which would cause a stroke. Let's look a little at atherosclerosis now. I take this out, I put it back in, and I take it out. Every time I take it out, it's like, you guys really need this, and I think this can't hurt you. This isn't really my subject, but this is more Cooperstein's subject. Mine's more the pathology. But anyway, I put it back in, so it's in. So atherosclerosis, Cartland Clinical Pathology, a really well-written text, maybe not quite deep enough, but says there's no other disease in the Western world that inflicts so much morbidity and mortality on the human than does atherosclerosis. And it's basically a clogging of the pipes where you get a decreased lumen. How's the blood flow going to be through this pipe? Is it going to be easy, or is it going to be not so easy? It's going to be really hard, so they can cause a Beaver Dam. Loves the abdominal aorta too, so it can cause a really big Beaver Dam. Remember atherosclerosis? I think we've talked about this. This is a member of it's one of the three subclasses of arterial sclerosis is the main heading. Arterial sclerosis has three subdivisions: Monkberg's medial sclerosis, arteriolosclerosis, which is a clogging and a narrowing of the arterioles. That's the most important cause for blood pressure. No one even talks about it. And then atherosclerosis. So it is a major contributing factor to some deadly diseases. Coronary artery disease, if it occurs and it blocks an artery, you get a heart attack. Cerebrovascular disease is basically a stroke if it clogs up one of the middle cerebral artery, and it causes a complete Beaver Dam. You get a massive stroke. It may not make it through that one. It can also it loves the abdominal aorta, and it loves the external iliac arteries, and it can completely clog those up, and you get severe ischemia to the lower limbs. Not to mention the heart is trying to pump through that Beaver Dam, so you're going to get hypertension in the upper arms and hypotension in the lower arms, or in the lower limbs if you did a blood pressure. But the heart is working very hard to try to overcome that, and you can wreck your heart with that stuff. Robin says it's a 50% contributing factor in almost all deaths in the Western world. Why do you develop atherosclerosis? It's a two-pronged approach. Number one is inherited, congenital factors, like your LDL receptors don't work, right? They don't soak up LDLs like they're supposed to, and too many LDLs can be all mischievous, as we'll see. And then there's acquired factors, just basically your diet and smoking, right? There's acquired factors right there. That looks delicious, doesn't it? Although really it's so big, it's going to hurt you. Get TMJ trying to eat that thing. It's kind of too big, but it looks delicious. But yeah, you can't eat that thing every day, right? The cheese and the bacon and all the fat, and that's going to stimulate the process of atherosclerosis. Smoking, hypertension. If you have hypertension, you should be lowering the stress and salt to help fight it. And then there's congenital factors, as we said, mutated LDL receptors, and primary hypertension is genetically passed, and sometimes heart just pumps too hard, and you have hypertension. We don't know what it is. Some common targets of atherosclerosis: we got the cerebral arteries, so the brain, the heart, the coronary arteries, the renal arteries. If it affects the renal arteries, what's that going to do to your blood pressure? Well, the Beaver Dam here, the heart's going to pump harder to get through the Beaver Dam. That's going to elevate blood pressure a little bit, but you're also going to release you're going to turn on the R2A system. You're going to release renin, try to correct the pressure in this kidney. It's kind of a double whammy there. Loves the abdominal aorta and the iliac arteries. What is it anyway? It is an inflammatory disease. And again, it loves the large arteries. It loves the abdominal aorta, the iliac arteries, the femoral, even the popliteal. And it loves the special arteries, the coronary arteries, cerebral artery, carotid artery, renal arteries. What's the sequelae? Well, we said this already. If you clog up your coronary arteries, you're going to get a heart attack. Or if it clogs them up a lot, but not all the way, you'll get some warning signs. You'll get angina. You'll get chest pain, which is tissue ischemia of the heart when you try to go upstairs. You get a TIA symptoms if it clogs up the cerebral arteries. If it clogs up a cerebral artery completely, you get tissue death downstream, and it causes a stroke. Secondary hypertension from renal artery stenosis. PAD, we've talked about peripheral arterial disease. It can definitely cause peripheral arterial disease. which symptoms of that, intermittent vascular coagulation, and you end up getting your limbs cut off for that if you don't fix that. How about some fun facts about it? It's a high pressure phenomenon, so you don't see it in the smaller arteries. There's not enough pressure. The whole process is driven by LDLs sneaking between endothelial cells and getting underneath the endothelium and sparking an inflammation process. And so you have to have really high pressure to do that. So therefore, this process doesn't usually occur in the arteries or in veins or in the lymph system. And it could take 20, 30, 40 years to manifest as a heart attack or a stroke or angina or a TIA. What clogs up the pipes? Well, it's the process of atherosclerosis, as we'll learn here in a second. The end phase of atherosclerosis is the formation of a plaque, which is really a beaver dam. And yeah, these plaques can appear in people your age, but they usually don't cause trouble until you get in your 50s or 60s. It takes a while for the beaver dam to get into full play. Here's a beaver dam that's formed a plaque. So there's all these foam cells in the inside, and we'll look at this process in a minute. And the slippery 3 aren't working here, so it's really easy to start developing thrombus formation, which worsens the beaver dam. There's a real butterflied abdominal aorta, and you can see all the gunk and the plaque. And yeah. 4 ways plaque creates disease. In other words, 4 ways the beaver dam can create disease, and the process of forming the beaver dam creates disease. Well, it's going to narrow. It pushes into the lumen, right? Go back to this. Is the lumen not narrowed? Yeah, look at the lumen. There's the lumen. It's not supposed to be. It's supposed to be this big. So you've just really decreased your blood flow. So it narrows the lumen. So you got decreased blood flow to the tissue downstream from that. So that tissue is going to be upset, and it could become painful. So yeah, so that's a problem. And then you have let's go back to this. So you have your heart up here. There's your heart. So you have your heart sensing that the tissue down here is ischemic. It's not happy. It needs oxygen. So the heart is going to increase its power of contraction, try to force more blood through here to make this happy, but it's going to wreck the heart. The heart can't keep doing that forever. And you'll eventually get cardiomyopathy from that, dilated cardiomyopathy if you want to get specific. But yeah, so that leads to increased hypertension, as we said, or just that the beaver dam causes hypertension and wrecks the heart. If it happens in the renal arteries, it turns on the artery system. So that's stenosis. It could also completely occlude a vessel via a phenomenon called breaching. Sometimes when let's go back to this thing, and we'll look at this again, but this is capped here by endothelial cells, and there's also smooth muscle cells which have moved. But if this cracks open and blood starts to get in here, there's tons of coagulation factors in here. And this, within minutes, 3, 4, 5 minutes, you can develop a gigantic thrombus formation, and it can completely clog up this vessel. So now you're not happy anymore. The tissue down here is basically dead. Right? And if that happened in the heart, you'll have a heart attack. If it happens in the brain, you'll have a stroke. So that phenomenon of when this breaks open, when the endothelial cells and the smooth muscle cells break open, it's called breaching. All right. It also, the inflammation going on can weaken the blood vessel that's affected with atherosclerosis. And if it weakens, you can form a gigantic aneurysm down there. Let's go back to here. So all this inflammation right here can weaken this to the point where we can start getting blood pushing down and causing the blood vessel to develop a saccular aneurysm because of all this weakening here. Maybe occurs like that. Right? We've talked about that before. And yeah, and then of course the aneurysm could burst, right? And that's like hemorrhage, and you talked about that. It's hemorrhagic stroke or hemorrhagic shock you can go in, which is one of the types of hypovolemic shocks. And then thrombus formation. Yeah, if you get an aneurysm, we've talked about how thrombogenic that is. You can form a really bad aneurysm. There's no laminar blood flow in there. Right, a little water break there. Yeah, and then the slippery 3 aren't secreted too, so that's another way with thrombus formation, because those endothelial cells are in inflammation mode and they don't secrete the slippery 3. All right, let's get into this response to injury hypothesis. Now, I think you've had this. It's been around for a long time, but it's still quite popular. And atherosclerosis begins when LDLs sneak between adjacent endothelial cells. They get underneath the endothelium. The body sees them. There's blood vessels. There's microcirculation in there. And in comes the troops. So you get a wicked inflammation going on. Right? How does it get started? What could cause the endothelial cells to breach? Because normally, here's a blood vessel wall. Endothelial cells are really tight together. Here's the blood flowing here. And an LDL molecule will try to get in here, and there's no way. It can't get in. But if there's a space between these and the LDL molecule gets underneath here, then holy hell breaks loose, and you get a rip-roaring inflammation, and yeah, well, that's atherosclerosis. How does it get started? Hypertension, anything that puts stress on the endothelial cells and makes them either shrink or beats them up to the point they're not sealing very good. Dyslipidemia, so that's having high cholesterol levels, high LDL levels. If you have high LDL levels, maybe from faulty LDL receptors, if there's too much LDL floating around in your blood, the odds are some of that LDL is going to find a way to get underneath the endothelium and inside the wall of the blood vessel and spark this inflammation. Cigarette smoking causes a inflammation. Some of the particles in cigarette smoke are thought to cause an inflammation that can damage the endothelium to the point where LDLs can sneak in. Hypertension just beats up endothelial cells and makes it more likely that LDLs can sneak in. Abnormal blood flow can also beat up endothelial cells to the point the gaps between them widen so endothelial cells can get in. Inflammation from a virus, inflammation from autoimmune, just inflammation of the endothelial cells can cause them to shrink, and LDLs can get in. Anything that beats up endothelial cells can stimulate the start of atherosclerosis. So here's a cartoon of this. And, oh gosh, I hope my pointer's been working. I'm sorry if it hasn't. I'll put it back on. It's that virtual classroom. You can't use this in virtual classroom, so I got to get used to using this again. But yeah, so here's all the LDLs. You see that for what maybe this person has hypertension, these two endothelial cells are beat up and damaged. So these LDLs have found a way to sneak inside here. And now we're going to get a wicked inflammation brewing right here, right? That's atherosclerosis, right? The monocytes are going to come in and turn into macrophage and start to eat these. We'll see the whole process here. But that's the start. LDLs have to get underneath the endothelium. And, well, this is just describing if you have too much LDL around, it's easy for LDLs to find a spot like that. And mutated LDL receptors are one way that people have high levels of LDLs. So LDLs are very mischievous. It's more important than your cholesterol number, too. My Stanford cardiologist is always on my case about that. My cholesterol's just a touch high, but my LDLs are much higher, and I always argue. I said, my cholesterol's fine. And he goes, it's not about the cholesterol, it's about the LDLs. So LDL levels are the key. Once under the endothelial cells, all hell breaks loose. So the first story is monocytes will track down those LDL molecules that are in the wrong place. And remember, LDLs, who do LDLs carry inside of them? Cholesterol, right? So now you got cholesterol and LDLs. But monocytes go in through the same hole where the LDLs went through. And once the monocytes get out of the blood, they change names. They're still monocytes, but they convert into macrophage, which have ability to crawl and move more. So they morph into macrophage. Macrophage eat them. So here's our cartoon. We got LDLs that have snuck in here. And here comes a monocyte. And monocyte's going to get in there, and it's going to be just like Pac-Man eating the LDLs. They need to be tagged, though. The body will tag them, will oxidize them. I don't know how important that is, but to you guys, if that's too deep, I won't get into the process of that. But the LDLs are oxidized once they get into the underneath the endothelial layer, and then the macrophage eat and eat and eat until they just are blown up like 10 times bigger than normal. And once they get that big, they change names to foam cells. A foam cell is nothing but a macrophage, which used to be a monocyte, and it's overstuffed, and it's even yellow in color because it's eaten all these foam cells, which are yellow. You can even see these if you put a camera inside the blood and affected, like inside the aorta, and someone who has this, you can see these foam cells because they're yellow, and that you can see through the artery, and they give rise to these fatty streaks like this. Here's a fatty streak here. So this is a macrophage that's overstuffed. We're calling this a foam cell now. This is a foam cell, another foam cell, and they start to cause bumps in the endothelium because they're so overstuffed. All right, what do foam cells do? They release cytokines, chemokines, and they call in more inflammatory molecules like T cells. A full-blown inflammation occurs underneath the endothelium. And so now the inflammation is raging in the subendothelial space. What's that? That's the space underneath the endothelium. And that's the process of atherosclerosis. That's why it's an inflammatory process. And now something amazing happens, and I didn't know this when I went to school, but there's not enough macrophage to eat all these LDLs that are pouring in, and so we need help. Where do we get the help from? The smooth muscle cells, which you think of are just contract for contraction purposes. Smooth muscle cells some genes get turned on in them, and we don't know what the signal is, but they develop pseudopodia, little hands and feet, and they can literally crawl out of the tunica media and crawl in to the battle zone, and they can phagocytize LDLs too. So not only do macrophage phagocytize oxidized LDLs, so do smooth muscle cells. Right? So we can see that smooth muscle cells, something has turned on different genes in these things and woke up the ability for these to act like phagocytes. And they come in here, and now they're eating LDLs, and they're blowing up and getting bigger and bigger. All right? Now all this piling up of monocytes or of macrophage and smooth muscle cells, foam cells, and engorged smooth muscle cells, it's really starting to bulge out the endothelium into the lumen, and it's decreasing the size of the lumen by this point. And when it's visibly decreasing the size of the lumen, that part that sticks into the lumen is called a plaque or an atheroma. Okay, the plaque is made up of mainly foam cells and overstuffed smooth muscle cells. But that's going to cause a beaver dam and all the sequelae we talked about with a beaver dam. Upstream hypertension, downstream hypotension, and downstream ischemia. If that's happening in your brain or heart, that's not a good thing, right? So now here's the kind of the next step. So here's the war. All the foam cells are in here. They're not drawn, but there's overstuffed smooth muscle cells in here. There's a big inflammation process going on here, and now the body senses that the endothelial lining is about ready to break because it's stretching too far. So some smooth muscle cells, they don't become phagocytic, but they wall off. They form another layer right under the endothelium here to make it thick. But that just further decreases the lumen here. But this is a plaque that's born. Some authors say that the plaque occurs once the smooth muscle cells wall off the inflammation and are immediately underneath the epithelium. That's a plaque, and it's a beaver dam. Okay, we talked about this. And if eventually the plaque can break loose, and then all hell really breaks loose. If that plaque cracks open and blood flows in there, there's tons of thrombogenic factors in the battle zone, including von Willebrand factor, factor 8, things that are very powerful at clotting blood. And so if you get, that's called breaching when it breaks open. If breaching occurs, you get the formation of a blood clot immediately, within minutes. And it usually completely clogs off that artery, causes a full beaver dam. If that happens in the heart, you're going to have a heart attack. If it happens in the brain, you're going to have a stroke. Here's a cartoon where breaching has occurred, and blood has flowed in here, and it's just basically clotted the blood immediately. And it's going to clog this entire artery up. This could break off as well, right? You could break this off and you could have an embolism. This is thrombus, classified as thrombus material, so you could have a big embolism break loose as well. All right. Let's talk about blood pressure now. Switch gears. So you know these blood pressure guidelines that 2017, the American College of Cardiology and the American Heart Association made that changed all the blood pressure guidelines, and you had to memorize them. Well, for my class, you don't have to worry about it because they haven't made it into Rubens and Robbins or Bates or Seidel yet. We talked about that in lab, but blood pressure is now categorized as normal, elevated, stage 1 or stage 2 hypertension. And then hypertensive crisis as well. So for me in my test, you don't have to worry about this. I'm just teaching by the board books here. So hypertension is anything 140 to 180. That's just hypertension. They don't even call it stage 2 hypertension, at least not yet. Maybe this will trickle down another 5 years into the board books, but it hasn't made it yet. So you have systolic hypertension if you're above 140, between 140 and 180. You have diastolic hypertension if you're above 90 to 120 zone. If both of these are elevated, you just have it's called hypertension. If it hits 180, that's a medical emergency. That's hypertensive crisis. Or if it goes over 120, the diastolic number goes over 120. These people are admitted to the hospital. These are really, really serious, life-threatening conditions. Blood pressure is very, very well regulated. The capillaries have to have the right amount of hydrostatic pressure, as we've said before, because you want remember we have to have hydrostatic pressure higher than oncotic pressure at the distal capillary, or at the proximal capillary. And then it has to switch. The oncotic pressure has to be higher than the hydrostatic pressure at the distal capillary, so we get a return of interstitial fluid there. That's why the body is very stingy. Pressure has to be just right. And so the arterioles control that pressure inside the capillary. And hypertension will occur there's many reasons for it, but if the arterioles vasoconstrict to control the pressure through, that raises blood pressure even more. Elevated blood pressure is called hypertension. I hope you better know what that means. It's definitely a contributor to premature death and disability and stroke and heart dysfunction. It's also a major risk factor for the development of atherosclerosis. Right? If the pressure is high in your arteries, it's going to beat up more endothelial cells, so it's easier for LDLs to sneak between them. There's also increases the risk of getting SARS-CoV-2 infection, which of course causes COVID-19 disease. What are the symptoms of hypertension? Usually nothing, right? That's why it's the silent killer, because it's asymptomatic until it gets high enough up into the malignant hypertension range, and then you get headache and visual changes and confusion and chest pain. Those are signs of malignant hypertension. Blood pressure fluctuates with each heartbeat. Yeah, it rises during ventricular systole and it falls during diastole. Hope if you don't know that, you're in big trouble. We've already discussed the elastic recoil, how important that is for shutting those semilunar valves. Arterial pressure is, ideally it should be, for systolic pressure, should be about 120 or maybe a little less. Diastolic pressure should be about 80. Hypertension is defined by all of our board books as anything at or above 140/90. Hypotension is anything below 90/60. Blood pressure is influenced by 4 factors, some little physiology. Stroke volume, which is stroke volume plus heart rate is cardiac output. You could say cardiac output as well. But it's the volume ejected from the blood. So these are the factors that affect blood pressure. If you increase the stroke volume, if you push more blood out per beat, you're going to raise your blood pressure. The total distensibility of the arterial tree, really the arterioles, the stretchiness of the arterial tree. If the walls are stretchy, the pressure is going to be lower because, especially in the ascending aorta, it's going to absorb that blast of systolic blood. If the walls are stiff and it doesn't absorb, kind of cushion that big blast of blood coming out of the ventricles, it's going to pass that pressure along to the whole arterial system, and that raises blood pressure. And then the resistance as well, how big the lumen is. Increase in the peripheral resistance will decrease the lumen of the diameter, the lumen size, and that increases blood pressure as well. And we talked about how arterioles can act as a beaver dam. And then blood volume. If you have too much blood volume, you have hypertension. We've talked a lot about having not enough blood volume, and that causes hypotension. Blood pressure maintenance, so you can adjust the stroke volume to compensate for blood pressure changes. So if a vessel gets narrow, the heart must contract with more force to push through those vessels. This can wear out the heart over time. We've said that like a million times already. You can adjust the peripheral vascular resistance, mainly the lumen size, to compensate. If a patient has a failing heart, you can vasoconstrict arterioles, which will increase the pressure and help perfuse the organs. How do they vasoconstrict? The R2A system and the natriuretic system. That's how they vasodilate. We haven't talked about that yet, but we'll get to that soon. And I'm not going to ask you questions on this. I threatened to do this one time, but this is not my zone. This is Pazuli's law, but just to show you the relationship between blood flow and blood pressure. So it's inverse to length, inverse to viscosity. It's directly related to the radius. Increase the radius, or by a factor of 4, increases the blood flow. You know this. I'm not going to get into that, though. What are the major risk factors for hypertension? Atherosclerosis, right? It increases, especially if plaques forming, that's going That's going to decrease the lumen size, and that means you're going to increase arterial resistance if you have a smaller lumen, and that will increase stroke volume to try to overcome that. That increases heart rate and myocardial contractility, which increases blood pressure. Renal failure is another risk factor for hypertension. How can that be? Well, remember, sodium is dumped into the proximal convoluted tubule and it needs to be cleared. Most of it is soaked back in to the body, but in renal failure, principal cells and proximal convoluted tubule cells, they might not be very good at pulling sodium out. So, if you can't pull sodium out, you can't pull water. That would cause hypovolemia. But in other types of renal failure, you just can't even get sodium out through Bowman's capsule. So if you can't clear sodium from the blood, then you can't clear. Water's not going to follow it, so you're going to have too much hypertension. So that's a mechanism there. Depends what type of renal failure we're talking about. All right, chicken and the egg. Yeah, because hypertension is a cause of atherosclerosis, and atherosclerotic plaquing increases hypertension, so you get a chicken and the egg scenario, where hypertension, if you get an increase in hypertension, it increases atherosclerosis. If you get an increase in atherosclerosis, it increases hypertension, so you get this vicious cycle because of this. And yeah, it is the silent killer, right? You don't have symptoms until all the damage is done to the heart, to the coronary arteries are 90-95% clogged, and you start getting angina. Look at that number. A third of all Americans have chronically elevated blood pressure. That's just crazy. It's a huge problem. What's the natural history of hypertension? If you start developing it, like say in your 40s, where are you going with this stuff? This is an oldie but a goodie. It's the Farmington heart study. Studied this extensively. It showed us that systolic pressure normally increases slowly starting in adolescence, and it continues to rise and rise and rise. So that's because the arteries get harder and harder and harder. Diastolic blood pressure is kind of an enigma. It increases with age, but strangely it stops increasing typically in the 50s. When you're in the 6th decade of life is the 50s. And then it starts to slowly decrease. So that's very strange. It might be because of a weakening heart, but they're really not sure how that phenomenon works. What about isolated hypertension? Is that a possible? Yeah. If your blood pressure is at 140 or above, you have isolated systolic hypertension. And some people, this is all they have. It's common in older people over 55. It's especially seen in females over 55. It's a major risk factor for heart failure. My voice is starting to go, so take a little water here. And so what's the mechanism? What's the pathogenicity behind this systolic hypertension? Typically occurs to one of the arterial scleroses. It's usually atherosclerosis is involved in systolic hypertension. It's basically a hardening of the pipes. So arterial sclerosis hardens the pipes, and therefore it's lost its compliance. It's lost its stretchiness. When systole occurs, all of the blast that's coming out of the left ventricle is not absorbed anymore by the ascending aorta and the aortic arch. It's passed right on down the system. So pressure wave is going to be much stronger than normal because there's no give in the ascending aorta. Isolated systolic hypertension, who's at risk? Well, then older adults. But here's the one that I always get you on, and you mess this up on the exam. It's also seen in young people, 17 to 25. This is the main type of hypertension. And surprisingly, it's not seen in smokers or people who are couch potatoes. It's seen in athletes. The prevalence of young male athletes in some studies is up to 25%. They're usually cross-country runners. It doesn't affect women athletes, and it's a very strange phenomenon. It's got to do, they think, with sympathetic, too much sympathetic tone, or an overactive sympathetic nervous system always has a vasoconstriction going in the tunica media. And therefore it simulates, in these athletes, it simulates having atherosclerosis or arterial sclerosis. It simulates having hard, non-stretchy arteries. And that's what they think it's about. Two types of hypertension: secondary hypertension. That means the etiology is known. It's only about 5% of the diagnoses, although a lot of times it's not worked up properly. You have to remember, we talked about how important in GIGU, we talked about how important it is to get the ratio between renin and aldosterone to see what the story is there. But primary hypertension is called essential hypertension, and 95% of the time that's it. And so we don't know. There's some theories. Some people, the salt genes, some people don't clear salt well. I think I took all that out because we just don't have time for all that. But some people can't clear salt. That way, if they go on a salt-free diet, it'll help them. And endothelin, some people are thought to over-release endothelin. It's a bunch of theories about this, but it's still not really been proven. Hypotension is low blood pressure, anything under 90 to 160. The authors can't really agree on what those numbers are. Those are Robbins and Rubens. Typically an asymptomatic problem. We don't even worry about it. When do you worry about hypotension? We worry about it when symptoms start showing up. A patient starts getting really dizzy when they stand up fast to the point of passing out. Then we might have to act on that, because that's getting to the point where it's affecting the organs, and there could be some damage, organ damage, because of it. It's typically caused by a disease that decreases cardiac output or decreases peripheral vascular resistance. In other words, causes vasodilation. Causes of hypotension, oh my God, look at all the stars. You got to know this one. Medication, older people can have hypotension because of a failing heart, can cause hypotension, but even some of the medications that they have to take if they have an arrhythmia, beta blockers, calcium channel blockers, diuretics, arrhythmias can cause hypotension. Valvular disease. How can valvular disease? Aortic stenosis. If the aortic valve is stingy and doesn't let all the systolic ventricle blood out during a contraction, you're not going to have much pressure. Heart failure. Maybe the heart just can't contract hard anymore. That's hypotension. Blood loss, we've talked about, definite hypotension. Cardiac tamponade, which is a failed right ventricle because of some cardiac disease. Cardiac tamponade is blood in the pericardial cavity that's squeezing the heart and not letting the heart eject enough blood. Decreased sympathetic outflow. That could do it. Nitric oxide, the ratio, the kind of balance between nitric oxide and sympathetic inflow is off. You'll have too much vasodilation in the system, and you'll have hypotension. Dehydration, blood fluid's gone. Blood is mostly water, so we've talked about that before. Severe anaphylaxis. Well, your blood fluid drains out into the interstitium. You're not going to have blood fluid. You're going to have hypotension. Addison's disease. There's your aldosterone. You need aldosterone and you need cortisol to have proper blood pressure. Aldosterone causes reabsorption of salt and water. And secondary adrenal insufficiency could do it. Diabetes insipidus. We've talked about all that, so I assume you know that from GIGU. All right, that'll do it. See y'all in the next one.